on trying to get all those graded for you all. Okay, so before we pivot into what we're going to talk about today, are there any questions? Anybody have any questions? All right. Well, excellent. Well, so what we're going to talk about today is we're going to move in and we're going to talk a little bit about fluid and electrolyte balance. Specifically, a lot of the terminology surrounding that. Today will be a little short, so we'll probably only go an hour, maybe an hour and a half, and that'll give you all some extra time to work on homework over the weekend. And of course, there are some pre-recorded videos that I've loaded into Canvas under Lecture 5. So you'll see there are 5, Part 1, Part 2, Part 3, all of them say pre-recorded. And those lectures will focus on specific electrolyte abnormalities. So hypo and hypernatremia, or sodium anomalies, hypo and hyperkalemia, hypo and hypercalcemia, and so on. So some of the major electrolyte anomalies that we run into, some of the key findings, signs and symptoms, what kinds of things cause these electrolyte anomalies, and what treatments, if any, are available in the pre-hospital context. So let me go ahead and share this with you all, and we'll just roll right into talking about fluids and electrolytes. And more specifically, we're going to start off talking about how do we measure all of this, and what do some of these terms mean? All right, so let's talk about these. So just as a review, when it comes to fluids and electrolytes, we have solvents and solutes. And as we remember, a solvent is something that is able to dissolve other substances. In the context of human physiology, water is the quote unquote universal solvent, and we have some understanding of why that is based on the prior coursework we've done in the chemistry of life. And then solute is stuff that gets dissolved in water. So solvent dissolves and solute gets dissolved. So solute consists of typically of ions and smaller molecules, although there are some larger molecules, certain proteins like albumin, immunoglobulins, antibodies that can act as a solute as well. But they are ions and molecules, and they tend to be fairly polar molecules because, remember, water is a polar molecule, and so it tends to interact with polar molecules. And so there are two terms that we use to describe the movement of both solvent and solute molecules. And so when you see the term osmosis, osmosis refers to the movement of solvent. All right, so osmosis is the movement of solvent. It's the movement of water. And we say that solvent moves from low solute concentration to high solute concentration. Get back there. To high solute concentration. So essentially, solvent moves towards solute. On the other hand, we have what's known as diffusion. And diffusion refers to the movement of solute, not solvent. So diffusion is the movement of the dissolved particles in the water. And solute moves from high solute concentration to low solute concentration, right? And so that is a little different from osmosis, where the water is moving toward the solute, right? The water is attracted to the solute, right? Whereas solute tends to move away from itself. So for example, if I have a glass of water and I drop a little sugar cube into that water, the water molecules are going to be attracted to that sugar, but the sugar is going to start moving away from itself out, and it's going to dissolve into the water, right? So there will be both osmosis and diffusion occurring at the same time. And then in cells, what happens is we have a semi-permeable membrane, and that completely changes the picture. But these are the core concepts behind that. All right. So when it comes to measuring solute concentration, there are also some additional concepts that we need to be aware of. We have talked about some of these already. The concept of an equivalent, right? This is what we tend to measure solute, specifically charged solute. So whenever you see equivalent being used, we're talking about electrically charged, right? We're talking about ions, electrolytes, right? So an equivalent, just to review, is how much of an electrolyte, right? And remember, electrolytes are ions, cations, and anions dissolved in water. How much of an electrolyte do I need to have 1 mole of electrical charge? Remember, 1 mole is an Avogadro's number. That's 6.02 times 10 to the 23, right? And remember, we could calculate that by the number of moles of ion I have multiplied by the charge of that ion equals equivalent. For example, if I have 1 mole of sodium, that's 1 mole times 1 charge, because sodium has a +1 charge, right? So I would have 1 equivalent of sodium. Other ions have different amounts of charge. For example, magnesium is in group 2, and so it will have 2 electrons in its valence, and so it tends to lose 2 electrons when it becomes a cation, and so it will take on a +2 charge. So if I have 1 mole of magnesium ions, right, I do not have 1 equivalent, but rather I have 1 mole times the +2 charge, or this just a 2 charge, gives me 2 equivalents, right? And then we tend to break the equivalent up because it into another unit is more relevant for biochemistry, and that is the MEQ, or the milli equivalent. And remember, the milli equivalent is 1/1000th of an equivalent, right? So if you divide equivalent by 1,000, that is 1 milli equivalent. So there are 1,000 milli equivalents in 1 equivalent. And then we tend to then talk about that as milli equivalents of ions dissolved in a liter of solvent, right? All right. But there are some other concepts we need to be aware of, and that is something called an osmol. An osmol is where I have 1 mole of osmotically active particles. What does that mean? Whenever we say something is osmotically active, what we're saying is that it causes osmosis. So if something is osmotically active, it acts as an effective solute in that it pulls water toward it. Water is attracted to it. It acts as an effective solute. So not all molecules are going to be very osmotically active. Most of what we're going to be talking about today will be, however, but that's what an osmol is. It is 1 mole of osmotically active particles. And so when we are talking about calculating or measuring the solute concentration, specifically in the human body, there are 2 very similar concepts that can be used. There is the concept of osmolarity with an R, and osmolality without an R. Osmolarity is how much solute do I have dissolved per, or how much solute do I have dissolved per liter of solvent? Per liter of solvent. Okay. And so that will be measured in milliosmoles per liter. And a milliosmol, or an MOSM, is just 1/1000th of an osmol. All right. Now, osmolality, on the other hand, is how much solute do I have dissolved per kilogram. So it is a weight-based measure instead of a volume. And so that is measured in milliosmoles per kilogram. Now, the actual values, if you were to measure the osmolarity and the osmolality of the human body, the actual numbers that you will get are going to be very similar, because 1 kilogram of water equals 1 liter. All right. So this is very close, right? If it doesn't matter if it's osmolarity or osmolality for the most part, because 1 kilogram of solute equals 1 liter, right? And so in reality, the values that we get between these two are going to be very same when we're measuring the solute concentration in the body. All right. So again, these measure how concentrated or diluted a solution is. And the important thing to know here is we are only looking at the concentration of one solution. So we're drawing a sample of blood plasma, and that tells us the solute concentration dissolved in that sample of plasma. It doesn't tell us anything about maybe something going on inside of a cell, for example. All right. And just to let you know, normal blood plasma, the osmolarity is approximately 300 milliosmoles per liter. Or if we're talking about osmolality, the normal blood osmolality is about 275 to 295 milliosmoles per kilogram. So you can see the values are very close to one another. And if you ever hear the term hyperosmolar, for example, certain disease conditions can make a patient's blood plasma hyperosmolar. What does that mean? Well, that means there is a greater concentration of solute in the blood. The blood is too concentrated, right? There is less water and more solute, and so the blood is hyperosmolar. Classic conditions that can cause this are conditions where there is too much sugar. And can you give me an example of some conditions where there is too much sugar in the body? Oh, say that again.
Like hyperglycemia.
Yeah, give me some. There's some specific examples of hyperglycemia where there is a markedly elevated blood sugar.
Hyperosmotic non-ketonic.
Okay, yeah, something called HHS. That's hyperosmolar hyperglycemic syndrome. Sometimes it is also referred to as hyperosmolar hyperglycemic non-ketotic coma, or HINC. Hyperosmolar hyperglycemic non-ketotic coma. So HHS and HINC, that they're the same thing. And so that's a situation where you have incredibly, like sometimes over 1,000, oftentimes over 1,000 milligrams per deciliter of sugar concentrated in your body without ketones. What's another example of a situation where we can have markedly elevated blood sugar?
DKA.
Yeah, DKA is the other classic example, diabetic ketoacidosis. So those would be two good examples of a situation where the blood is hyperosmolar because there is so much sugar in there, and it is essentially the blood is too concentrated. And so what that's going to do is that is going to draw fluid out of the cells, right? Because water is attracted, it's going to pull fluid out of the cells. And then the kidneys are going to be working to try to get rid of that excess sugar, which means you will be losing lots of fluid, lots of water, because the only way that you can get rid of sugar is by keeping it dissolved in water and then eliminating it as urine. And so these patients in these hyperosmolar states tend to be profoundly dehydrated. All right. And then just to also give a couple more examples of certain IV solutions that we commonly give to patients. If we look at 0.9% saline, for example, it has a calculated osmolarity of about 308 milliosmoles per liter. In actuality, it's about 286 after it gets administered. So you can see that it is fairly close to the osmolarity or osmolality. In this case, we're talking about osmolarity of human plasma. And that's sometimes why people call it, quote unquote, normal saline, because it is more or less, this is somewhat contentious, and there are lots of discussions to be had around this. We won't have them today, but we will talk about normal saline and some of the problems that may be associated with it. But more or less, it is the overall osmolarity is approximately what you would see with normal blood plasma, hence the term normal saline. If we look at another commonly used solution, lactated ringers, also known as Hartmann's solution, it has a total osmolarity of 276, but its effective osmolarity is actually 248. So this is a situation where some of what's in lactated ringers will not act as an osmol, and specifically the lactate. So lactated ringers, right, contains a little bit of some sodium. It contains a little bit of potassium, a little bit of calcium, and it also contains a little bit of lactate as well. And after you give the lactated ringers, the lactate gets taken up into the liver and into the Cori cycle and gets goes through gluconeogenesis and other cycles. And so the lactate doesn't really stay in the blood and doesn't act as an effective osmol. So we have to eliminate the lactate, and that's why it drops from 276 to 248. Excellent. So that is the concept, or rather, those are the concepts of osmosis, diffusion, osmolarity, osmolality. Everybody okay so far?
Yes.
Okay. So now the question is, well, this is all fine and dandy, but the body is very compartmentalized, right? All the fluid in your body just doesn't sit in a big open reservoir like this glass of water that I showed up here, right? The water in your body exists in certain compartments, and those compartments are separated by cell membranes. And cell membranes, the way that a cell membrane works is typically solute cannot go through a cell membrane. So if I draw a cell membrane, right, it's the phospholipid bilayer, and then embedded in that cell membrane, we have little pores, actually known as aquaporins. And then we have other protein channels. And sometimes these protein channels can allow solutes to move in or out. All right, so this is the phospholipid bilayer here. And so water can move more or less freely into and out of the cell, but solutes are not quite as free to move, right? So if a solute needs to get into the cell, it may have to be pumped in through active transport or some other mechanism. It's not free to move. And so what happens is, if you have a whole lot of solute accumulating outside of the cell, that's going to effectively, right? That's going to effectively exert osmotic pressure. It is going to cause osmosis. And so that will tend to pull water out of the cells, right? And likewise, if the concentration of solute inside of the cells is higher than outside of the cells, then that will tend to draw water into the cells, and the cells will swell. And if the cells lose water, they will shrink, or what we call crenate. And so we need some terminology or some concept that we can use to compare the solute concentration on one side of a semipermeable membrane to the concentration on another side of a semipermeable membrane. And this is where the concept of tonicity comes into play. Tonicity. So whenever you hear the term tonic, hyper, iso, or hypotonic, right, that is referring to a difference in solute concentration from one area to another, separated by a semipermeable membrane. So when we compare the osmolarities or osmolalities of two or more solutions separated by a semipermeable membrane, i.e. intracellular, extracellular, the concept of tonicity comes into play. All right, so let's just talk about tonicity here. So if I have a cell here, so here's my cell, and I have some solute in that cell, okay, and then I have the same concentration of solute outside of the cell. Now, it doesn't need to be the exact same ion or molecule. It just needs to produce the same osmolality or osmolarity, right? So you could have a bunch of potassium inside of the cell, which we do, and as long as there's a bunch of, say, sodium, something that exerts the same kind of osmotic force, right? So, right, then you will have a stable situation. So it's not the exact particle that counts, it is the concentration, right? So for example, if this is outside of the cell, it's 300 milliosmoles per liter, and inside of the cell, the concentration of all the solutes is also 300 milliosmoles per liter. This is what we call an isotonic situation. And that means that is to say that the amount of water coming into the cell is equivalent to the amount of water leaving the cell. So going in equals leaving, going in equals leaving, going in equals leaving, right? It's balanced because the concentration of solute is the same. So this is an isotonic situation. So when you are administering an isotonic crystalloid IV, for example, right? And a crystalloid is just an IV solution where you have tiny crystals, ions dissolved in water, such as normal saline or lactated ringers, right? You would have a roughly speaking, an isotonic solution. That is to say that that solution is isotonic with respect to your blood plasma. Now, on the other hand, I can have something called a hypotonic situation. And what I'm going to do is I'm going to talk about that in reference to this cell again. So I'm going to draw the cell here. And again, the cell has some solute dissolved in it. and then there's some solute dissolved outside of the cell. All right, and so let's just say that the osmolarity is 300 milliosms per liter inside of the cell. And let's just say that it is 200 milliosms per liter outside of the cell. So let me ask you all a question. Where do you think the water is going to go in this situation?
Inside of the cell.
Yeah, it's
Yeah.
gonna be
So the concentration of solute is higher inside of the cell than outside of the cell. And so remember, the solute would like to get out of the cell, but it can't because it can't go through the semi-permeable membrane very easily. And so what happens is water goes from outside of the cell into the cell because that solute attracts that water. So water goes into the cell and the cell begins to swell. This is a situation where we would say that the plasma, the extracellular environment, is hypotonic compared to the intracellular environment, and water will go into the cell. So an example of a condition where you can have hypotonic situation is something called hyponatremia. That is a low sodium concentration in the blood. Because remember, sodium is the primary extracellular cation. So when we have low amounts of sodium, that will make the blood hypotonic. There are also hypotonic IV solutions. We tend not to give them. But if you gave somebody, say, pure water, for example, that pure water would be very hypotonic compared to the blood and the intracellular space. And so if you gave somebody pure water, you could actually harm them immensely by causing their cells to swell. And specifically, when you have cells that begin to swell in compartments of a body that don't expand, like the cranium, and you get cerebral edema, and that can be neurologically devastating. Let's see here. And then the last thing I want to talk about is what we call hypertonic. And so if we use the same cell paradigm that I've been talking about, let me draw another cell here. So in this case, I have some solute in the cell, and then I have some solute outside of the cell here. So in this situation, let's say that the osmolarity is 300 milliosms per liter inside of the cell, and let's say that's 400 milliosms per liter outside of the cell. So where is the water going to go in this instance, in this case?
it'll remain
Trying to go out.
cell.
Out of this.
Out of the cell.
Good. So there's more solute outside of the cell than inside of the cell. And so the water is going to move through those aquaporins by osmosis outside, and the cell will shrink, it will lose water. And so we would say that the extracellular environment is hypertonic compared to the intracellular environment. And so in that situation, that's going to draw fluid out of the cells. And so if you give hypertonic IV solution to somebody, you will cause fluid to shift out of their cells. So if you give something like 3% saline, for example, it's called hypertonic saline, that will make the blood plasma more hypertonic, excuse me, and that will pull fluid out of cells. And sometimes this is used to treat, say, cerebral edema when the brain is swelling, and we want to pull some fluid out of those swelling neurons and glial cells. So is everybody okay on what tonicity is?
Yes, sir.
Okay. So again, tonicity is, you have to have some comparison for tonicity. All right. Well, excellent. So then this is going to lead us into another discussion about, so we've been talking about the solute a little bit. Let's talk about the solvent in a little bit of detail as well. And again, the major solvent is water, right? And we say that when we look at the average human body, right? So this is that generic 70 kilogram adult male patient that we're talking about here, but we'll go with it. About 40% by weight. So we're going to go with weight first. So about 40% of the body by weight consists of solid material. And then approximately 60% by weight is water. All right. So 60% of that 70 kilogram patient is going to be water. I'll keep that up there. And we can generally divide this water into certain compartments. And the two major compartments are the intracellular space and the extracellular space. So the intracellular is within the cells, and approximately 63% of that water exists within the cell. So most of the water in your body exists within the intracellular space. And then you have the space outside of the cells, and that's approximately 33 to 37% of the water is in the extracellular space. And then the extracellular space is further subdivided into a couple of compartments. And those compartments include the intravascular. So inside of the blood vessels. And so of the extracellular space, or of the extracellular volume, 20% of that volume exists within the vascular space, and then 80% exists within what's known as the interstitial space. This is a space in between the cells, and this is sometimes referred to as the third space. And so when people have fluid accumulating in the interstitial space, we'll sometimes say they are quote unquote third spacing. All right. So that's kind of how the water is divided up in the body. So let's figure out by volume what we're dealing with. So if I take that generic 70 kilogram patient, I can actually figure out total body water, right? So I know that when talking about water, remember 1 liter of water equals 1 kilogram. So if I take that 70 kilogram patient, I can multiply that by 0.6. That's 60%, right? Because I want to figure out what 60% of 70 kilograms is. And that's going to give me the total body water. And that gives me about 42 liters of total body water, right? So of that person, you're dealing with 42 liters, or about 42 kilograms of that 70 kilogram patient is water. So, and maybe what I'll do is just do that in a different color, 42 liters. All right. So now what we can do is we can take a look at the various compartments. All right. So what I'm going to do is I am going to look at the intravasc, or the intracellular compartment first of all. And so of the total of the 42 liters of total water that I have in this 70 kilogram person, all right, so I've got 42 total liters of water. I'm going to multiply that by 0.6. or 0.66, somewhere in there, 0.63 to 0.66. And when I do that calculation, that gives me 27.7 liters. So I've got about 27 of that 42 liters within the cells. And then I'll go to the extracellular and I will multiply that by 33%. So I will go over here and I'll start with my 42 liters of total body water, 0.33. Now I'm just kind of simplifying this, 66 and 33, just to make the math a little easier for us. And when I do that, that gives me about 13.9 liters or thereabouts. So I have, of that 42 total liters of body water, I have approximately 14 or 13.9 liters in the extracellular compartment. And then we'll further divide that into the vascular interstitial. So again, I will, let's go to the interstitial compartment. All right. So I have, of that 13.9, I'm going to multiply that by 0.8, right? That's 80% of the total amount of water that I have in the extracellular compartment. And that gives me about 11 liters. So 11 of that 13.9 liters is in the interstitial compartment. And then finally, the vascular compartment. All right. So again, 13.9 liters, and I'm going to multiply that by 0.2. That's 20% of that 13.9 liters. And that's going to give me about 2.7 liters. And so 2.7 liters of water. So I've got 2.7 liters of water in the vascular compartment, 11 liters of water in the interstitial compartment. And that makes up 13.9 liters in the extracellular. And then I have the other 27 liters in the intracellular to give me a total of 42 liters total body water. So that's kind of how the water is divvied out. Now, this is just the water we're talking about, right? So you might look at that and go, well, you have more than 2.7 liters of blood, right? And you're absolutely correct, because remember, blood is not just water. There is other stuff in the blood. Oops. Just had a crash there. There we go. All right. Sorry about that. So there's 2.7 liters of water in the vascular compartment, but then you have all of the solute, right? The blood cells, the proteins, and the various ions and electrolytes dissolved in there. And that makes up the rest of the volume, right? Because you have about 5 to 6 liters of total blood volume. And then 2.7 liters of that 5 to 6 liters is water. So is everybody okay with that so far? Everybody okay?
Yes, sir.
Okay, sweet. So then what I'm going to do is I'm going to move on, and I'm just going to spend a little bit of time talking about edema. And this is actually covered fairly decently in the textbook, but let's just move on nonetheless. So when it comes to edema, edema is essentially fluid where it doesn't normally belong. Oftentimes that is fluid accumulating in the interstitial space, but a fluid can accumulate other places too, right? If you have cerebral edema, for example, that's fluid accumulating inside of the brain. So when we talk about edema, edema is fundamentally a balance between two major pressures. So there are two major pressures, and we're going to look at the blood vessel here when we talk about fluid going into and coming out of blood vessels. And so we have what's known as hydrostatic pressure. And hydrostatic pressure is the pressure, think of it as the pressure that is pushing fluid out of the blood vessel. So that is hydrostatic pressure. So you can kind of think of it as just the blood pressure, just the pressure inside of the vessel. So that is hydrostatic pressure. And then the other major pressure you have is something called oncotic pressure. And oncotic pressure is the osmotic pressure that various solutes, right? So various things dissolved in the blood or the fluid, right? That exerts pressure. And remember that water is attracted to those particular solute molecules. And so that is going to pull, right? That is going to pull water toward it. So oncotic pressure is pressure that keeps water in the blood vessel, and hydrostatic pressure is pressure that pushes water out. And so when you have a mismatch of hydrostatic and oncotic pressure, you can have fluid leaving the blood vessel. So one of the easiest ways for that to happen is for the blood vessel itself to become leaky, right? And so you have little gaps that open up in the blood vessel, and that just allows fluid to leave, right? So you just have hydrostatic pressure pushing fluid out of the blood vessel. And so what are some situations that can cause the blood vessels to become leaky? We often refer to this as increased permeability. And oftentimes this happens in the capillaries. Well, things like inflammation, right? When you twist your ankle, for example, what happens? It starts to swell up. Why? Because you cause injury to those tissues. Those tissues release what are called chemokines and histamine, and then that acts on the capillaries and blood vessels in that injured area, and those blood vessels open up, become permeable, and then that allows fluid and other things to leak out of the blood, right? Specifically, it allows white blood cells like neutrophils and macrophage or monocytes that become macrophage to migrate out of there. And that's actually something called diapodesis. We'll talk about that in immunopathology a little later on. So inflammation can cause that. Allergic reactions, so allergies, and of course, anaphylaxis. And this can become a marked problem in the setting of the soft tissues of your airways, right? And that is often referred to as something called angioedema, right? Where the tongue swells up, the airway mucosa swells up, and that can sometimes in severe cases cause airway obstruction, right? That's one of the life-threatening consequences of anaphylaxis. Okay, certain shock states can do this too. For example, septic shock. And septic shock belongs to a category of shock states referred to as distributive shock, where you have a redistribution of body fluid. And a septic shock and anaphylactic shock are two specific examples of distributive shock. Where you get increased capillary permeability, right? So the capillaries swell, they dilate, and then they open up, all right? So those are some fairly easy examples. Let's talk about some other examples, however, right? Let's talk about the example of just hydrostatic pressure. What if the hydrostatic pressure gets really high in the blood vessels, and it's just the net increase of hydrostatic pressure that does it? There are several situations where you simply have too much hydrostatic pressure. And some examples of this would include heart failure, And you have several types, different types of heart failure, right? For example, if the left ventricle fails, blood backs up where? Where does blood back up if the left side of the heart fails?
In the lungs.
Blood backs up into the lungs, and the hydrostatic pressure of those vessels in the lungs increases, and then fluid gets pushed through those vessels due to that increase in hydrostatic pressure, and then that causes pulmonary edema. Now, what happens if the right side of the heart fails? Where does fluid back up?
In the very, so usually the lower extremities.
Yeah, so fluid backs up in the venous system in the body, and then you have increased hydrostatic pressure in dependent areas of your body, like your feet and ankles, right? And so you get swelling there as well. All right. And then another situation where we can get edema is a situation that involves the oncotic pressure. So what if I were to lose large amounts of solute in the blood, specifically large molecules that produce a lot of oncotic pressure? And one of the most important molecules that exerts osmotic pressure is a large protein called albumin. And when you lose albumin and you develop something called Hypo Albuminemia, low albumin in your blood, that will decrease, right, the oncotic pressure within the blood vessels. And that will mean that the hydrostatic pressure will more easily be able to push fluid out of those blood vessels. So an example of this would be hepatic failure, liver failure. So in liver failure, one of the many things that the liver does is it actually produces albumin. So when the liver fails, you're not able to create as much albumin. So you have a loss of albumin. All right. You have a decrease in oncotic pressure, and then fluid begins leaking out of the blood vessels, and you get fluid accumulating in areas of the body like the abdomen. And you can have lots of fluid accumulate in the abdomen. And because the liver is failing, fluid is backing up into the liver, and that's increasing the hydrostatic pressure. So you have an increase in hydrostatic pressure inside of what we call the portal circulation. The portal circulation. That just means the liver, the portal blood vessels, the liver blood vessels. So the hydrostatic pressure increases as the liver fails. The oncotic pressure decreases as the albumin levels fall, and fluid starts spilling out of those blood vessels. And where does that fluid tend to go? Can anyone?
If it's backing up into the portal vein?
Say that again?
If it's backing up into the portal vein, is that the question?
Yeah, so you have liver failure. So you have an increase in hydrostatic pressure in the portal circulation and a decrease in oncotic pressure due to a loss of albumin, because the liver can't make albumin anymore. So where does a lot of that fluid, as it backs up, where is it going to spill out into as it gets pushed through those blood vessels?
Interstitial space?
A little bit, but where else?
Abdomen?
Yeah, the
cavity.
abdominal cavity. Yeah, the abdominal cavity. And what is one of the signs of liver failure?
Ascites.
Ascites.
Ascites,
Jaundice?
yeah. Yeah, ascites, right? Where you get a swelling and distension of the abdomen, and that's both due to swelling of the liver and due to fluid accumulation in the abdomen because you have a backup of pressure in the liver and you have a loss of oncotic pressure. And so fluid is spilling out into the abdominal cavity. You can also get ascites with substantial heart failure. If you have bad enough right-sided heart failure, right, you can also get ascites. So ascites isn't specific to the liver. There are several things that can cause it. And of course, there are other indications of liver failure. Someone mentioned jaundice. That's due to an inability to conjugate and eliminate bilirubin in the bile. You get encephalopathy. We talked about that, hepatic encephalopathy due to ammonia accumulation. You get coagulopathy. That's a bleeding disorder and inability to clot because many of your clotting factors are produced in the liver. So you get a lot of different things going on. But I just wanted to give you some examples of some common conditions where you have alterations in hydrostatic and oncotic pressure that result in edema. All right. You can also have impairment of what's known as the lymphatic situation, the lymphatic circulation, rather. And the lymph vessels are just the vessels that reabsorb fluid in the interstitial space and bring that fluid back into the venous system, back into the vena cava. And before that fluid goes back in, it goes through a network of nodes called lymph nodes, where you have lots of white blood cells, and it kind of filters, quote unquote, that fluid out. And we will be talking about lymphatic stuff a little later on in the paramedic pipeline. All right. So is everybody okay with that there? Some other areas where we can have alterations on oncotic and hydrostatic pressures are things like altitude sickness. Specifically, you get to very high altitudes and the pressure is very low at those high altitudes, and you have a very low partial pressure of oxygen, and that can precipitate two life-threatening disorders called HAPE, high altitude pulmonary edema, and HACE, high altitude cerebral edema. So you get edema in the lungs and edema, swelling of the brain. So those are just a couple of other, I think those are mentioned in the text, in the reading of the textbook as well. All right, so let's see where we're at on time. So it's 9:26. So I think what we'll do is we'll take our first break. We'll come back and we'll go for about another half an hour, and then we will call it for the day. So before we take our first break, are there any questions? Anybody have any questions?
No, sir.
All right, so it's 9:26. How about we meet back up at 9:35? 9:35.
Hey, Chris.
Any questions before we continue? All right, make sure it looks like I'm good on chat. All right, excellent. So what I'm going to do now is I'm going to pivot and I'm going to talk about, we talked a little bit about water, about the solvent. And now what I want to do is I want to talk a little bit about electrolytes and some of the values, at least as in blood plasma, and how we measure them, and just some of the major issues that we run into with them. So let me go ahead and share the screen again. All right, so I'm going to talk a little bit about some of the major electrolytes that we're going to look at, and we'll go in more detail in the videos that are pre-recorded. But the major electrolytes when it comes to the body include sodium, or Na+. All right, that's sodium. and its level in blood plasma. This is all blood plasma because that's all we can really directly measure. You remember is 135 to 145 milliequivalents per liter. All right. And sodium is the major extracellular cation. All right. And then potassium is the next major cation that we deal with. That's potassium. But its concentration is much lower in blood plasma, 3.5 to approximately 5 milliequivalents per liter. And the reason that it is so much lower than sodium is that most of the potassium in your body is within the cells, and so it is the major intracellular cation. And there is a general rule of thumb that I want you to remember, and the general rule of thumb goes as follows. Sodium imbalances tend to impact the brain. So the major organ that's impacted when you have sodium imbalances is the brain, because sodium is very important as far as causing water to move, causing osmosis. And the rule of thumb is wherever sodium goes, water follows. All right. On the other hand, potassium imbalances tend to impact the heart. All right. So that's a general rule of thumb when it comes to sodium and potassium. Some other cations that I want to mention: calcium. All right. Calcium can exist as an ion dissolved in your blood, but it can also exist contained within the hydroxyapatite of your bones. And calcium is not only can it act as an electrolyte, but it can act as other things as well. But let's talk about it as an electrolyte. And really what I want to focus on here is low calcium. It's called hypocalcemia. When we have low calcium, because hypocalcemia can cause what's known as neuromuscular irritability. So in some sense, it's like sodium, where you have a lot of neurological issues. And there are two findings that I want you all to focus on. And these findings are what we know as what we call the Chavostic sign. The Chavostic sign and the Trousseau sign. Chavostic and Trousseau. And a positive Chavostic, just think of Chavostic cheek. When you tap on someone's cheek, that causes spasm of the masseter muscle. Whereas the Trousseau sign, think of that as the arms. And specifically, a positive Trousseau sign is when you put a blood pressure cuff on someone's arm and pump the blood pressure cuff up, that will induce carpal spasms. Carpal spasms are associated with a very high pH. We'll see that, right? With a very high pH. The pH is increased, you become very alkalotic. And so this will occur in severe cases of something called hyperventilation syndrome. You can get carpal tunnel spasms, but you also get them in the setting of hypocalcemia. So if we see these things, this suggests that somebody has life-threatening hypocalcemia. We're not really going to focus on the treatment so much today, just talking about some of your imbalance. Now let's see here. Magnesium is another one. All right. We see magnesium in far lower concentrations. And so its normal level is 1.3 to 2.1 milliequivalents per liter. All right. And whenever it comes to disorders of high and low, you will have a hypo and a hyper. And for example, with sodium, we say that a low sodium, less than 135, is hyponatremia. Greater than 145 would be hypernatremia. Potassium is kalemia. Hypokalemia, less than 3.5. Hyperkalemia, greater than 5. When it comes to calcium, it's just calcemia. Hypocalcemia, for example, and magnesium is just magnesemia. Hypo and hypermagnesemia. Let's talk about some of the negatively charged ions or anions. Chloride is the most substantial one that we see. And normal value in the body, and we talked about that, 95 to 105 milliequivalents per liter. And it is just chloridemia, so hypo and hyperchloridemia. All right. And these labs are all measured in something called the blood chemistry. So when somebody has a blood chemistry test done, this is a test that looks at these various, or some of these various electrolytes. And there are two major types of blood chemistry. There is something called the BMP, that stands for the basic metabolic panel. This is sometimes referred to as the Chem 7 or the SMA 7, because it looks at 7 different values. And sometimes when it is documented in a shorthand form. And this is sometimes referred to as a fishbone chart. So if you see a little diagram like this in the patient's chart, this is a fishbone diagram. And so this is actually the basic metabolic panel. And so the 7 things that we look at in the BMP include the following, and this is where they go. The sodium value would be placed here. The potassium value would be placed here. The chloride value would be placed here. The venous carbon dioxide, which is actually nothing more than the bicarbonate, HCO3. So just think of that as the bicarbonate. Something called the BUN, or the blood urea nitrogen. Something called the creatinine. And then the patient's blood sugar, their blood glucose level. Those are the 7 things that you look at on the SMA 7, or the basic metabolic panel, right? So if you see something like this, all right, you would know that their sodium is 140, their potassium's 4, the chloride is 100, the bicarbonate is 24, the BUN is 1, the creatinine's 10, and the blood sugar is 110, right? The BUN and creatinine, we'll talk about them in a little more detail, but I'll just mention them. The BUN and creatinine are the values that we use to determine renal function. All right. And the higher they are, that indicates impaired renal function. So a high BUN and creatinine suggests impaired renal function. Now, there is another blood chemistry. This is referred to as the CMP, the complete metabolic panel, instead of the basic metabolic panel. This is sometimes referred to as the SMA or Chem 12. And so it looks at not only the BMP, but it looks at some additional values. So it looks at the calcium. This is where you get the calcium level. Look at the albumin. All right. It'll look at the bilirubin. Look at the protein. And then it'll look at something we refer to as the LFTs. That stands for the liver function tests. All right. And there are three major ones that we look at: the ALT, the ALP, and the AST. All right. And so these here, the bilirubin, the ALT, ALP, and AST are all what we use to determine the liver function. And just like with the renal function, the higher those values, the more dysfunction. All right. So the higher your ALT, the higher AST, the higher your bilirubin, the more hepatic or liver dysfunction that we see. And then we know that in severe cases of liver dysfunction, your albumin may actually decrease. All right. So these are the main tests that we use to look at a lot of these electrolytes. If you want a magnesium, if you want to know somebody's magnesium, that is a test that is ordered by itself. It's a kind of a standalone test. It's not associated with the BMP or CMP. But most of the rest of these electrolytes are measured in either the BMP or the CMP. All right. So with that in mind, are there any questions over anything we've covered so far?
Not for me.
Okay, hopefully that's this is kind of the foundation. So what I'm going to do is I'm just going to go in and I just want to review, make sure we're all on the same page as to what's coming up, what needs to be done. So let me make sure I have that. I do. All right. So I'm just going to share my screen real quick. Let me make sure you all can see that. Okay, there we go. All right, so we go under acid-base fluid electrolyte. So the acid-base worksheet will be due. So those are the ABGs, the ABG interpretation. That'll be due Monday night. All right, the fluid and electrolyte worksheet. All right, that's the one I asked, maybe hold off on that until today because we kind of covered some of the information on that, and then the rest of it will be in the videos. And then there is this assignment, advanced acid base, where it actually consists of case studies. So you actually have patients with problems and you actually have an ABG and you get their labs, their ABG, and you get their blood chemistry. And so you're trying to figure things out based on pulling all the information that we've covered up to this point together. That will be due as well. So those three assignments. All right. And just as a reminder, whoops, let me go up. So if you go under lecture recordings here, under lecture 5, that's technically what today is, lecture 5. In addition to this lecture that we're doing that I'm recording, and I'll upload that later, but just remember there are 3 pre-recorded lectures. All right, there's fluid and electrolyte part 1, There's fluid electrolyte part 2, where I go into some detail in the blood chemistry and I talk about calcium and potassium imbalances, specifically how to approach them and how to treat them. And hyperkalemia is a very important one from a pre-hospital perspective. And then I will talk about sodium imbalances in detail, hypo versus hypernatremia, signs and symptoms, and some of the treatment considerations. And there's a very important pathophysiological consequence of not treating sodium imbalances correctly. It is called osmotic demyelination syndrome. So you want to pay attention to that when that comes up. All right, so you've got those 3 homework assignments and then these 3 videos to go through. I'll have office hours on Monday morning, starting at about 8:30. If anybody has any, you run into any major issues and you just want, or you just want to review something, or do you want to make sure that you're understanding something correctly, we'll have that time before all the homework is due to work any of those issues out. So with that in mind, I want to make sure everybody is okay with what you need to do and what's due and what you want to work on over the weekend. Are there any questions over any of that, or is everybody okay?
Yes, sir.
I'm good.
All right. I don't see anything in chat. All right. Well, I'm going to cut it off here. Again, we're going early, but that just gives you all a little extra time to get through videos and work on stuff. And I will see you, if not Monday, I will see you Tuesday morning.
Thank you, Chris.
Yeah, thank you all so much.
Thank you, sir. Have a good one.
Thanks,
You all
Chris.
do the same. Take care.